according to our regulations, is that they will respond and acknowledge what they're going to do. And so I wanted to share that they did do that. The advocate received that information, feels that it's appropriate, and will continue to monitor that. In the future, if we get it before our agenda deadline, a copy of that will be in your packet. So I just wanted to acknowledge that. Next meeting, you'll probably have one, for example, from Western State Hospital. So I want you to be prepared when that comes for what that'll look like. But generally speaking, the recommendations, if you remember, had to do with enhancing and reviewing all of their investigative materials and processes for investigations. They actually did update their investigation form to allow a specific space to document if the individual that's involved is not included in the interview or investigation, then the reason why not. And I think that was a big part of this committee's recommendations. So yeah, that's what I wanted to say about that. The last thing is to acknowledge that we're coming up on the end of the year. And so we need to start thinking about our meeting schedule for next year. So CLE will put together kind of a draft of dates based around kind of skipping holidays and making sure we have 9 meetings, and usually sticking with the same month that we've done. The meetings again will be on Thursdays. So you can expect to see that in your next packet. Our meeting is in November. The idea is that you'll kind of look at your calendar and think about if there's any conflicts, so that at that meeting in November, we can talk through it again, so that in December we can vote on it and have a meeting schedule that we can go ahead and post for the public. And then the last note is to talk a little bit about, not even a lot, just about our next meeting. I'm thinking that this is working well, having our meetings at this central location, all things considered with FOIA expectations. So my suggestion to this committee to think about for where you're going to be in November is that we consider having it here again, and that we consider trying to have our physical quorum here. And so that certainly if folks wanted to participate, folks being members wanted to participate electronically, that could be possible. But I would suggest that we continue to work at trying to have our physical quorum and all of our members who are able to meet here in November. Yep.
Great, thank you, Tanika. Are there any questions about the presentation yesterday, or did anyone have any comments on the packet that Tanika had sent out? Yes, all right, great.
Sure, so the department's state board, who are 9 volunteers that are appointed by the governor, and they, very much like this committee, but they oversee the activities of the entire Department of Behavioral Health and Developmental Services. And they are the folks that appoint you all as members. Yeah. No, the commissioner's not on the board. She reports to the board. And her presentation was actually right before ours. Thank
you so much. Well, I think we have just 2 minutes before we go into regular session, so we'll pause here for 2 minutes. Is that all right? Okay.
Yeah.
All right, everyone, I have 9:15, so we'll go ahead and get started if that's all right. So our first order of business is to review the draft minutes. Are there any comments on the draft minutes? And if not, can I have a motion to accept? Thank you. Do I have a second? All right. Yes. Welcome to the two new folks on our Zoom. If you'd like to take a minute to introduce yourself, we'll start with Becca.
Good morning, I'm Becca Herbig. I am a staff attorney with the Disability Law Center of Virginia.
Thank you, welcome. And Taylor?
Good morning, my name is Taylor and I am a intern with the Disability Law Office of Virginia.
Thank you, welcome. All right, and now we have the opportunity for our regulation spotlight, and I believe Reginald is going to lead us in that today.
Yes, let me share my screen. Someone give me a thumbs up if you can see the screen. Great.
Yep, we can see it.
All right. I've been asked to spotlight section of the regulations 12 VAC 35-115 110 seclusion, restraint, and timeout. And since I only have about 15 minutes or so, I'm going to highlight some of the key points of this section of the regulations for you. Let's start with a definition for seclusion. Seclusion means the involuntary placement of an individual alone in an area secured by a door that is locked or held shut by a staff person, or by physically blocking the door or any other physical or verbal means so that the individual cannot leave. Community providers should not be using seclusion unless they're a children's residential facility or inpatient hospital, and only then if they have approved policies. And you cannot use seclusion in a behavior management plan. I think Sheree Henderson went over that with you in her spotlight at your last meeting. So I'm not going to spend a lot of time on that area today. Restraint means the use of a mechanical device, medication, physical intervention, or holds to prevent an individual from moving his body to engage in a behavior that places him or others at imminent risk of harm. There are three types of restraints we're going to talk about today, and that's mechanical, pharmacological, and physical restraint, your holds. Mechanical restraints means the use of a mechanical device that cannot be removed by the individual. It restricts their movement, freedom of movement, or functioning of a limb or portion of the body in order to avoid or prevent a behavior that places the individual at risk of harm. An example would be a seatbelt for behavioral purposes. If the use of the mechanical device is voluntary and can be removed by the individual and is used for protective purposes, by definition on our regs, it is not considered a restraint. Pharmacological restraints means the use of medication that is administered involuntarily for the emergency control of an individual's behavior when that individual behavior places him or others at risk of harm and is administered medication is not a standard treatment for the individual's medical or psychiatric condition. In instances of pharmacological restraint, we're looking for a doctor's order with instructions and criteria for the use and discontinuation. An example would be a PRN Ativan for increased agitation. As long as the reason for the PRN is, in this case, agitation, is part of the individual's diagnosis, is identified as a problem, and the medication being given is part of the individual's medical history, it is not a pharmacological restraint. Providers should know what increased agitation looks like for the individual, and the provider should have a protocol for administering the medication. When a provider is using a medication that is not a part of the individual's history for a reason not diagnosed, the provider should have a restraint policy that specifically includes pharmacological restraint. And note, the provider should have a protocol for administering that medication as well. Physical restraint, also referred to as manual hold, meaning the use of physical intervention or hands-on holds to prevent an individual from moving their body and when the individual's behavior places him or others at imminent risk of harm. And we're not talking about general non-compliance or minor property damage. Providers should have a behavior intervention policy that specifically addresses staff training related to when, how, and why they use the physical restraint. And we're talking about TOVA, Therapeutic Options of Virginia, MANT, which is named after the person who created that behavior management protocol, Handle with Care. And then in some providers, they develop their own. And in those cases, if we're not, they send them to us for review. And if we're not familiar with or have some concerns about some of the techniques and holds they use, we usually will send those up to central office and have them to take a look at it to see if anyone up there is familiar with that particular intervention. And if they have any concerns, and then we relay that information back to the providers before approving that policy or protocol. And again, only children programs, residential programs, inpatient hospitals, DBH operated facilities, not training facilities, may use seclusion. And even then, providers must have approved policies prior to the use of the seclusion. Section 110 of this section of regulations provide that all individuals have the right to be completely free from unnecessary use of seclusion, restraint, or timeout. And note that an individual that requires support to maintain proper body positioning, balance, or alignment, and the individual agrees to use the mechanical support voluntarily, that mechanical support is not considered by our regulations as a restraint, nor is the use of protective equipment used voluntarily considered restraint. We would encourage you to pay close attention to the definitions, because the definitions give you a lot of information that would enhance your understanding of this particular section of the regulations, and those definitions under the human rights regulations you can find under section 30. All right. Restraint for behavior purposes means using any of the three type of restraints, and that's mechanical, pharmacological, or physical, to control behavior or involuntarily restrict freedom of movement of the individual in instances when there's an emergency, non-physical interventions are not viable, and safety issues require an immediate response. And for example, if a person was bolting and running towards traffic, and obviously your verbal interventions is not going to work, you need to do something right away to prevent that person from running out in traffic, then you're going to have to place hands on. That becomes a physical restraint by our definition, and the person is at immediate risk of harm. And that needs to be documented once you get back to your office, and that information would be tracked and reported to the department as a part of your annual report. Restraint for medical purposes means using any of the 3 types of restraints to limit the mobility of an individual for medical, diagnostic, or surgical purposes when the restraint is not an accepted clinical practice for treating the individual's condition. For example, using a lap belt for an individual that does not typically use a lap belt for body positioning in order to keep them still for an eye exam. Another example would be sedation medication for routine care or procedures related to post-procedural care processes. These typically would have a doctor's order for which all intents and purposes an LHRC or even an advocate cannot advise the provider against. However, if the reason for the use of any of these types of restraints are unclear or not documented in the individual service record, we could ask the provider to let us know. And in those cases, we can conduct our own independent review or request additional information for our own review, or request the LHRC to take a look at this particular situation or scenario. Restraint for protective purposes means using a mechanical device to compensate for a physical or cognitive deficit when the individual does not have the option to remove that device. Voluntary use of protective equipment is not considered a restraint. For example, an individual places a helmet on his head before he bangs it, and then takes it off once he finishes. If the individual that bangs his head and the provider places the helmet on the head and the person cannot take it off, then that would be considered a restraint. Not all restraints require LHRC approval, but any restraint, physical, medical, or pharmacological, including implementation in a behavior treatment plan, and that doesn't include seclusion, is subject to LHRC and or specially constituted committees review and approval after the independent review committee has reviewed it and approved that behavior treatment plan. Not all restraints require report in CHRIS, our Comprehensive Human Rights Information System. Providers should only report improper use of restraint and restraints resulting in an allegation of abuse or neglect in CHRIS. Section 230 of the Human Rights Regulations spell out the requirements for collecting and provisions for a provider to report their restraint data annually. This consists of information on each instance of restraint, including the duration, purpose, and rationale for it, as in the example I gave before when the person voted and was running out into the street. Timeout means the involuntary removal of an individual by a staff person from a source of reinforcement to a different open location for a specific period of time or until a problem behavior has subsided to discontinue or reduce the frequency of the problematic behavior. And timeout under our definition only lasts up to 30 minutes. And in our region, Region 5, we do have a variance to that for one of our residential treatment programs who use something called unit restriction that goes over the 30-minute time period. And just note that.
Hey, Reggie.
Yes.
Hey, Reggie, it's Tim.
Hey, Tim.
I got a quick question. Hey, how are you doing? It's good to see you. Quick question for you. Is there kind of like I'm reading this and it says open location. Is there kind of like an understood idea of what an open location is? Because we recently had an appeal that talked about an open location. It seemed like there was kind of some it seemed like there could be some interpretation of what open location was, and I don't know if you had kind of like an idea that's kind of standardized.
I can give you what I've seen. If someone is say you have a group going on, say where you're at now, and you had a group session and an individual started to have some behaviors very disruptive, not aggressive, but very disruptive, where you couldn't continue the meeting. Now, under our definition, it says involuntary removal. That means that they've gotten to a point where they don't have a choice. Now, in order to have them removed from the room, you may have to employ another restrictive technique, hands-on, to remove them once you get them out of the room. Or you can ask, and then if they voluntarily walk out of that room, then that's fine. But if you have to place hands on, you've employed another restrictive technique, they leave the room, then you offer the timeout again. Say, you can go down to the day room or a support room or hang out in the hallway. The whole point is that you're removing them from that area, and then their option is for them to just have a place to chill out. You're not requiring them to do anything else, but just leave that area. Now, obviously, if they're doing something else and start to attack others, then you may have to employ some other restrictive interventions.
Great, thank you.
Okay.
Very much so, thanks.
And finally, this is what we would ask a provider, and these questions, or they want to ask either the family member or whoever it is trying to have this person placed into their program, is these are the type of interventions we use. We use TOVA, or if I'm an acute care facility, we use seclusion in our facility. And then we would ask the person who's placed and say, do you have any other preferred interventions that work with this person if they become dangerous self or others? Is there any contraindications? Obviously, you wouldn't want to use seclusion if the person, when they were a kid, was locked in the closet while the parents went out. You wouldn't want to use seclusion if they're claustrophobic. Are there other less restrictive options available that you would employ for this individual? And then there's some other questions. Are staff trained? Are staff trained in our behavior management techniques prior to them being asked to work on a unit? We will hope so. And then do you have policies and procedures to address emergencies? Have they been reviewed by a qualified professional? And then not to be used as punishment or for staff convenience. So they can make a run to McDonald's, they ask the person to stay in their room. Remember, if they don't have the option to leave, you secluded them. And no restraints should place a person in a face down position. A lot of pressure on the chest, make it difficult to breathe for that individual. And it, hopefully I stay within the 15 minutes. Thank you. Any questions?
Thank you so much
You're welcome.
for the presentation. Are there any questions from the committee? I have one, Reginald, if you don't mind.
Sure.
Just about the I never recall if it's prone or supine, where the person might be face down. But do you know when that particular restraint was sort of eliminated from practice in CBHCS?
I don't know the year. Maybe Mary Claire might know, but I do know when there was some concerns raised because of an issue, and I won't get into that at a facility. I've been around a long time. But I'm not sure of the date and the year, but I do remember when it was changed.
Mhm.
Thank you. Looks like maybe Mary Claire froze.
I
somewhere.
know. I was
That's
going to
okay.
say, Reggie, do you think it was before 2017? I know I remember
Yes.
seeing it in our most recent revision,
Yeah.
but I did think it was before that. Yeah,
It was
like 2009.
Yeah, it was
Yeah.
well before that.
Thank you very much. Appreciate your time today.
Sure. Thank you.
I think that we are just about spot on for the public comment period, so I'll open it up to any members of the public that would like to make a comment now. Or 12 years ago for the restraint. Thank you.
I don't have a comment. I just had a question. I'm
sorry, I'm going to interrupt you there. I'm sorry, Sarah. This is public comment. We've gotten that guidance from our attorney. So if you have a question, maybe you could email me.
Gotcha. No worries.
Like a human rights question? Okay. I'll put my email in the chat.
Thank you. So I think we'll move to our guest presenters. Angela Hervell and Walton Mitchell. I think we're very good. If you have a presentation. Thank you. Mr. Walton, I wanted to just ask, is your microphone on? We have a chat that they are not able to hear you. I want to bring it up on this. Okay. We can access your slides. Are you ready?
It is now. I didn't know that I had to actually turn it on to be. Who knew? Oh, I can get lunch here. That's good. Get that. Talking for about 20. Okay, great. I have. I'll keep doing that. Let me introduce myself. I didn't do that properly. I'm Paulson Mitchell. Everybody will knows. Everybody knows me as Mitch. I have been to hospital system. Oddly enough, architecture and engineering the buildings there. But I have worked in CBHCS for 37 years now, 35 of those at Catawba, beginning as a clinical social worker, the last 10 as director there. So I have a great affinity for CBH and for the people that we serve. That way. Like I said, when we started this over a year and a half ago, nobody had any clue what was really going to happen, how the pandemic was going to evolve, how it would affect people, how contagious it would be, what we would need to do to keep the individuals that we serve safe, what we would need to do to keep our staff safe. Clearly, those all, like I say, I felt very insulated and isolated up at Catawba, which was not a bad thing for that. If you don't know, it's way out in the mountains. It's just in an absolute gorgeous setting. But it came to Roanoke like it came. About that time, I got asked to work down here for at least temporarily, working with all of the facilities. So I've been involved with developing the plans for the different actions we had to take relative to COVID during the past year and a half. First thing, from a statewide perspective, we did was we restricted visitors. That was a conduit for the spread of the virus at that time. How virulent it was at the outset, but that was the first action that the commissioners protect the individuals we serve and to protect our staff members. That was fairly standard across long-term care systems, medical hospital systems. We did make provisions for compassionate visits or end-of-life visits, things like that. But we're very careful in how even those took place. Have contagion coming into the virus coming into the hospital, because clearly hospitals, as we know, are one of the worst places for things like this. A lot of planning around changing our treatment programs to make sure that people were social distanced, that areas were cleaned between use. So if you're talking about having to clean group rooms from one group to another. So it really had a huge impact on our provision of treatment. The good thing is we were able to do that with a minimum of things that we had to shut down just because of the logistics. We were able to continue the provision of treatment throughout that in as safe a way as we possibly could. But regardless, anytime you have a congregate setting where folks are living together, even for short periods of time, you have a risk there. We clearly, as you would expect, had our infection control folks into high gear. we were working very closely with the Centers for Disease Control and the Virginia Department of Health throughout the pandemic, not just at the outset. We certainly relied upon them at the outset for guidance. We also utilized their expertise as this evolving crisis went on. Oh, absolutely. That's why I said. Always hate to mess with other people's computers.
Oh, you can just roll this thing down to go through them. Let me see if I can do it from my middle.
Great. But like I said, there are only 2 or 3 slides, so there's not. But now I can see it too. Thank you. I was up here trying to see it myself.
Am I in the right place?
Yes, you are. So clearly, each facility developed plans for infection control processes and procedures. Every facility did planning to develop isolation units and quarantine units. There's a difference there that I didn't really know at the outset, the difference between those. People I think use them interchangeably. Isolation means that's where we have people stay when they are positive, like they are infected. A quarantine unit is a unit where folks may have had exposure but aren't positive. It safeguards them should the virus develop. It keeps them apart from the rest of the population.
And in the physical space, could you describe the differences between if somebody was in isolation versus quarantine? Like, is that?
A lot of it has to do with PPE, and I'm sure you've heard that acronym, personal protective equipment. Everybody in the world now knows what PPE is, where it was nobody knew what it meant before. The level of PPE that both staff and patients use, the procedures for feeding are different, the procedures for feeding in terms of not the food itself, but all disposables and things like that when you're working on isolation units, because you don't even want your dietary staff handling the silverware. Quarantine units aren't a whole lot different from the rest of the units, except that people do not come and go from those. Treatment is brought onto the unit, and we try not to have staff. We try to have staff work only those units, not just patients, not just individuals who can transmit this into staff as well. So those are really the differences. But we try to minimize staff coming and going both on isolation and on quarantine units. Okay. All of the facilities, and I think we've all been in places that we went through the daily temperature, the symptom checklists and temperature checks. We have done that. That was placed in last March or April. It was one of the first actions taken and continues still. All of our facilities are still doing daily screenings for all staff. Like I told you, when significant outbreaks have occurred, we've called in VDH to consult with us. They've been very helpful. They have recommended at times that we close admissions at specific hospitals and for different lengths of times depending on the population. They've been more cautious, and rightfully so, in facilities where we're treating folks 65 and over. Catawba has where I've worked, had a geropsych unit. Piedmont Geriatric Hospital is all folks 65 and over. Eastern State has one of those units, and Southwestern State has one of those units. They have closed units at those places. They were generally for 28 days. So they were very cautious with that. When we had outbreaks and they closed units to admissions with adult patients, it was generally 14 days. And when I say closed, that means after the last positive test. So they wanted a period of time, sort of clean, if you will, before we took people back. Yes, ma'am.
Thank you. I had a question about how the quarantine rooms and the isolation rooms affected maybe the issue of seclusion and timeout that we talked about. Was there a waiver, or does certainly this, I mean, I understand the severity of course, but did there need to be a waiver? Because what you're describing sounds like seclusion or restraint in some ways. So was that something that was discussed or evaluated, or did people have to agree to be quarantined or isolated, or how did that work?
I can't say that we required that the first time around. It's interesting that you asked that, though. We have recently had to reimpose distancing restrictions and some things like that. And in consultation with Tanika, we think that is the right thing to do, and that's what we're doing now.
So in March, when the executive order came out, we did have a waiver issued by the commissioner so that isolation and quarantine could happen specifically in the community, because it's kind of a different setting. You're thinking about individuals being in their room, whereas in the state hospitals, typically they were quarantined and isolated on units. So they weren't necessarily limited to being in a room with a closed door. Correct me if I'm wrong. Right. Mm-hmm. Good question, though.
The other thing is, during the initial period, we were under an emergency order from the governor, and I think that's what you were saying, Tanika, as well as the commissioner. And but I think that is the way to go. After consulting with Tanika, we learned too. So that's what we're doing now.
Thank you. I wasn't questioning its use. I just wondered if there was, a process to go through it. Definitely made sense. So thank you.
No, that's a good question. Very good question.
I am Tim. I've got a question. So if you put admissions on hold and you still had people coming, where were they going if the state hospitals were closed for admissions?
All of our facilities have multiple units. Most of them have more than one admission unit. So like we had to quarantine or isolated. Our isolation units were generally created in and of themselves. They were new units, if you will. Most of the facilities didn't have that infrastructure. Well, had the infrastructure, but just hadn't set up their staff and their programs that way. So the isolation units were new units. The thing is, at some point, if it became predominant enough, if the infection rate was high enough, that's when we would consult with CDH. And if we closed admissions to that facility, we would divert them to a different facility. I think the most we ever had closed at one time were 3 facilities, and that was really at the height of it. Last winter and spring. Let's see. All of the facilities have been involved in. It says weekly meetings here. We were having 4 or 5. We were having daily meetings with facilities, with Craig Camage, our emergency coordinator for the state, with Dr. Aplaska, who is our chief clinical officer. So it says, I wish they had been weekly. I was on daily calls about COVID, really up until the early summer time this started. We cut them back a little bit, but we've ramped them right back up now as the positivity rate has increased again. Fortunately, according to Dr. Plaska, as of yesterday, it looks like it, and who knows the ultimate outcome, but it looks like it may be leveling off some of the positivity rates and the infection rates. So hopefully we've seen the worst of this round of infections. We also, as time went on, we improved our ability to obtain and give tests to our patients and staff. You know, at the outset, we were having to send them out to hospitals to get tested. The turnaround could be anywhere from 4 or 5 days to a couple of weeks, and an infection that moves this fast, that's really not terribly helpful. But as the technology evolved and the availability evolved, we ultimately had the ability and got the testing equipment to do those tests, both the rapid antigen, which is the quick test that isn't quite as specific. Got the technology to do those in-house at all of our facilities, and then we had quick turnaround contracts with outside labs to do the our testing, the sort of the gold standard testing, if you will. So that's really come a long way in a year and a half, not just for us, but for all of medical hospitals and as well as psychiatric and long-term care facilities. Oh no, I do that. I can do that now. Throughout the pandemic, the commissioner has held firm that that the state facilities will not admit known positive patients. Now, we work closely with the Virginia Hospital Healthcare Association around that. I can't say that's always been smooth, but we have found places for the folks who were known positive, who were referred to state hospitals. That wasn't always an easy or smooth process. I spend every third week on call for admissions problems throughout the case, so I can tell you we put in a tremendous amount of work to find places to make sure that folks could receive both the medical and the psychiatric treatment that we need. But the commissioner and the Secretary of Health and Human Resources did not feel like we had the medical capacity to provide that within our state facilities. Developed contracts for those who became positive while in the hospital. We did develop contracts with UVA for the treatment called it'll come to me in a minute once I stop. But the IV infusion that is supposed to help reduce the severity of the symptoms. All of the facilities had a contract with UVA that they could refer and take people up there to get that treatment. So we did have, you know, what was known as the best possible treatment available to all of our folks. PPE resources, I talked about that at the outset. Everybody was getting their hands on every piece of PPE they could, and that certainly limited our access as well as everybody else's. I will say our procurement department did a yeoman's job of obtaining and keeping us in PPE, but it was not easy because you got to figure with 12 facilities, 2/3 of those staff working shift work, so you were really supplying PPE for 3 shifts a day. You're changing it out depending on the type of PPE. For about a year, our procurement officer, his picture on his email, rather than his face, it was this huge stack of crates of PPE that he had in his storeroom waiting. So if that gives you an idea of the picture of what we were doing there. PPE is not as nearly as big a problem now. The supply has caught up. We did have to be careful of what we were buying. There was a lot of bad PPE, fake PPE, PPE that did not meet the standards that it was that they said they met out there on the market, and we found that before we ever distributed out to the facilities. But I can't say that the department never bought any. There were a lot of shady characters selling a lot of PPE out there for a while. The other thing we did, and I helped write the facility section of it, is develop crisis standards of care. That's something you'll hear in healthcare organizations. Basically, that's a set of things that you would do if you are overwhelmed by numbers of patients, overwhelmed by lack of staff, overwhelmed by sick people, by the level of illness that they experience. So we set up those plans really before we had any idea how bad this might get. We never had to utilize most of them, and the things we did were pretty benign in terms of, changing staffing and things like that to when we had COVID outbreaks among staff or things like that. But they were there, but fortunately we didn't have to use them for the most part. Okay. Yeah, no, that's good. That's it. That was the last of the points. I will give you, we developed teams at each facility early on to manage the vaccination process. We were fortunate to get access to vaccine fairly quickly. Camage and his crew, the emergency management folks, really had set up a structure for how to get it out and how to get it in arms before we ever got our hands on it. So we were really fortunate. And fortunate because folks planned well. Number of vaccines that were given. Right now, I just looked this morning. We have across the state, 72% of our staff are fully vaccinated, with a high of 90%, and that's up at Northern Virginia Mental Health Institute. And I think our one that has struggled the most is the Virginia Center for Behavioral Rehabilitation down in Southside. They're at about 57%. The other piece is I checked this morning our positivity rates within the hospitals. We have 51 positives, all but 13 of those are staff and are quarantined out of the quarantined or isolated outside of the hospital. So we only have 13 individuals within our system who are COVID positive right now. So given the prevalence rates, we knock on wood that those stay down that low. That's the end of my formal presentation. Questions, thoughts?
So I just got word yesterday that I guess Southwestern, I live in that area. I guess 30% of that staff is still not vaccinated. It's my understanding as of yesterday.
I think that's about right, 28 to 30. David, I didn't recognize you back there. I just now looked at your nameplate. We go way back.
Good to see you.
Good. I think that's right. In fact, I was talking with Cynthia yesterday, Cynthia McClaskey, the director down there. That's in Marion, and vaccination rate in the community is still a struggle down there. Yeah. And the prevalence rates down in that part of the state are still really high. We're fortunate to have the low number of cases down there, but most of them are staff cases that appear to be community acquired. So you're spot on, Dave.
I just wanted to ask, were there any initiatives to, I guess, consider the air filtration systems in any of the facilities? I've heard of schools, just kind of altering the air filtration systems and things like that. Was that part of any of the consideration around the COVID response?
Our facilities are so different. I mean, they go from Catawba, the main building was opened in 1952, right, to the newest with Western that was opened like 3 or 4 years ago. So we didn't really have one size fits all, because the facility, we have no two facilities that are the same. The closest are Catawba and Piedmont, and they were both 50s era tuberculosis sanatoriums before they became state hospitals. We have used them in spots. We have used them in day rooms and congregate areas and things like that in some of the hospitals. But as far as the mass, a whole system, filtration systems, I don't know of any of the facilities that have been able to do that.
Right.
That's a very good question, and something that we've been aware of.
Yeah, I would imagine it'd be an arduous task just because of that, because of the history of some of those buildings. So, okay, thank you.
Mitch? Vaccinations for staff facilities, is it still completely voluntary?
They are voluntary to the point where, as you probably read in the press for the last couple of weeks, you don't have to be vaccinated. But if you're not vaccinated, you have to be tested weekly. And we are very serious that you have to be tested weekly. That is not optional. That is not a loose system. We are taking that very, very seriously. We have got to protect the people that and we got to protect each other.
Yeah.
Staff needs to protect some medical systems are mandating that and making employment a condition.
Unemployment are mandated. So.
Yeah, I mean, I have a bias. Yeah, I respect people's rights. Any movement, toward a mandate, or is staying sort of that voluntary status? Okay.
That would come from the governor's office, but I haven't heard anything more about that. Personally, I don't disagree with you, Will, but
yeah, no, thank you.
I can tell you, I am vaccinated. I was vaccinated the first day I could possibly be vaccinated, and I will get my booster the first time that I can get.
I wanted to add some human rights context. I really appreciate you being here physically with us. Thank you, and for preparing this presentation. I wanted to acknowledge a couple of things. You mentioned the crisis standards of care, and the Office of Human Rights was actually part of that conversation. That was kind of like one of those worst case scenario plans, right? Like if we don't have enough medicine and we've got a lot of people to treat, or if we don't have the best set of standards and circumstances, what are we willing to throw off the boat to make sure people are safe? And that was a very scary, but also very interesting. And I was kind of proud to be a part of that we were thinking that far ahead. So I just wanted to acknowledge that I was thankful that our office was invited into that conversation. And then second, I want to also acknowledge and thank the facility system for opening up their doors and allowing our staff, who are considered central office staff and not facility staff, to come in and be vaccinated. That was really important to our office, and we appreciate that. And then also, the facilities have been willing to consult with our office, and oftentimes reaching out to me before I think to reach out to them around things like testing. You know, are we allowed to require testing? About vaccination, about, you know, authorized representatives giving consent to vaccination, about visitation. So lots of issues that at face value may not feel like a human rights issue, but we've been having those conversations. And I'm just so thankful that we've been able to do that openly. And I will say this on the record, that they've listened to our voice, right? They've been like, okay, well, we need to pivot and think of a different direction. Or sometimes the medical science requires us to do things differently as well. So I just wanted to acknowledge that.
Thank you. And I'm sorry, I didn't mean to make it sound like just facility services or DBH proper. This took a lot of work from a lot of people and a lot of cooperation. I just, looking back over the past year and a half, I can't believe how this has evolved and what we've done. It's almost unbelievable what a system can do.
It really is a remarkable effort, and you know, congratulations and gratitude for all those efforts.
Absolutely.
Well, thank you, and thank you for your support. That's the most important thing. But I'm sure the individuals we serve thank you as well.
Mm-hmm.
That's all I had formally. Any other questions? Or
Thank you so much for your time today, Megan. Yeah.
I have one more question. Do you know, like, staffing ratios across the facilities right now, or percentages about where y'all are at?
That's a very good question. That is a very good question. As you know, COVID has exacerbated a nationwide staffing problem.
Yeah.
As you've read may have read in the press, we have worked with a couple emergency contracts to bring in contract staff. We have struggled with staffing. I can't tell you I don't know our specific ratios off the top of my head. But we are working with recruitment and retention bonuses, stepping up, as well as bringing contract staff in. Contract staff are a stopgap. We've been working with a company who's done a pretty good job in sending us good folks, but that's not as good as having full-time, what we call P14, permanent staff, and that is a struggle. And it's funny, it's a little different in different areas. Some with RN, some struggle with LPN, some struggle with direct service, what we call direct service aides, a direct service associate. So it's different in different parts of the state, but none of the hospitals are able to get everybody they want and need right now.
Yeah. Thank you so much. Before we stop, I just want to make sure that nobody online has a question. I don't know if there's anything in the chat.
I know that folks weren't able to see the presentation, but we will include that as an attachment to the minutes.
Thank you so much for your presentation today. We very much appreciate it. So next on our agenda are the facility reports. And Mary Claire, it looks like you're up first. Give us just a second, maybe we'll.
Can y'all hear me?
Yep, give us just a second. I think Clee's going to help us out with the projector, or with the screen.
What I should do here.
You should be able to see my report. Can y'all see it? Can you hear me?
We can hear you. The screen looks blank. It says that you started screen sharing, but we don't see a document.
Huh, it says I'm screen sharing, so I'm surprised it didn't come up.
Oh, there you go. There you go.
Okay.
We see it now. Thank you.
It took a little bit of time. So, what you see is the seclusion restraint numbers for July. I first want to point out Western State for their hours of restraint went way down. They have, again, like Mitch was talking about, stopped TDO admissions. They never stopped forensic admissions. So they were still taking jail transfers, and they were taking anybody from that had NGRI status. So that never stopped. And as you know, with Central State, they never stopped their forensic admissions, their NGRIs, or their jail transfers. What we did stop was the TDOs. So you'll notice that for Western, that hours of restraint is usually in the 1500s. It went down to 877. For the 617 in seclusion, they have the variance for one individual, and he had upwards of 300 hours, like about 320 hours. So that's why that was so high. So it's still a handful of people that have the most seclusion restraint at Western, but I will commend them that they came way down. And I've already looked at August numbers and September numbers, and they are looking very well in addition to the July numbers. They also, with an individual, for when we in November, when I give the other data, you'll see that they went way down in restraint and seclusion because they are working a different plan with someone. So they're definitely working on getting their seclusion restraint numbers down, and still working on it. For Central State, again, theirs didn't really increase. It stayed about the same. That's typically what their numbers are. It's a 98 for seclusion and 112 for restraint. Eastern State went up a little bit, not dramatically. Their hours of restraint are usually below 100, and their hours of seclusion are typically in the 60 or 70 range. But Eastern was one of the facilities that had when we meet monthly for what's called a KPI report, and we're given staffing numbers at that time frame. And typically Eastern has had the worst staff shortages. Not sure why that is, but they definitely are struggling there, as well as at Western. MVMHI went up because they never closed to admissions. They were one of the few facilities that took other people admissions when they could. And so they never closed their doors. So their seclusion restraint hours went up a little bit. They typically are about 100 less for seclusion and restraint. But again, they were getting folks from all over the state that they normally wouldn't get, and still struggling with staffing issues themselves, but not nearly as bad as some of the other facilities. Southern, again, had no restraint, which is good. And their person that there was only a couple of people that had those seclusion, but they, again, were open at first, but then closed to their TDO admissions. Southwest never closed admissions. So their restraint hours were a little bit higher this time. They're usually not that high, but in the scheme of things, it really wasn't that bad. They didn't go up near as much as MVMHI did. But MVMHI, as you can see, had more admissions and discharges typically than any other facility. because I'll go over the patient screenings next, and you can tell that by that information. Already talked about Western Catawba had they don't use seclusion, had very few hours of restraint, which is great. CCCA, you will notice that they are way down, mainly because they only have about 12 to 13 children and adolescents at the facility. So their numbers went down dramatically compared to what they have been, due to not having as many kids at the facility. I'm not sure when they're going to open up, but they are another facility that is having a really tough time with staffing. And that is why they went down to so few beds. PGH, again, they usually don't have much, and they didn't have much this time. VCBR had 8 hours, and Tony will go more into that with his report. But I believe that was one person that had most of the hours. Hiram Davis had nothing, and Southeastern only had an hour and a half, which is typical for them. Their events were, as far as what they had for injuries, did go way down. They had been higher when the staffing issues were bad. They're still not great at some of the places, but compared to in September numbers are looking much better. We were having, when I was reporting this, and still am reporting it, to Angela and Tanika and Mitch, and it was about 7 or 8 a week, and now it's only 8 a month, or 2 for Southern Virginia, 8 for Southwest. We had 5 deaths in August. Let's see, 1, 2, 3, 4, 5, 6 deaths in August. And most of them were expected. So none of them were not expected. And so not that we ever want deaths, but they weren't unexpected deaths. Even the one at Central, the individual had cancer. So that's what happened there. The admission screenings, again, most of them, the only place that was not at the 85%, which is what they're supposed to be at, was Southern. I have already contacted them. And again, this is more related to their staffing issues, because they did have to close to admissions because of staffing. So when your staffing is short, then you have issues with trying to get things accomplished. So that's it for the report. Any questions?
Mary Claire, I have one question. This is Julie. For the Western State, it's really interesting to me that the hours in seclusion and restraint went so far down after the patients the TDOs had been paused. Is that something that you already capture in other parts of your data? You know, what kind of patient requires seclusion, or is that noteworthy at all to you?
Yeah, for them, it was, it's still that they have the folks that are using it the most, and they have about 5 outliers that use seclusion restraint the most. For seclusion, it's that one that's a variance, and he's using, he's pretty much in seclusion 24/7, and they have to report it as seclusion. Because of Joint Commission and CMS, whereas Central State has somebody in that situation as well, but they don't have to report it because they're not CMS certified, and Joint Commission is a little bit different for them. So their numbers don't look as bad compared to Western because of that one individual. With their restraint, again, it's a combination of staffing, and it's a combination of, with one of their individuals, they're trying different options, and that seemed to bring it down. So in September, you'll see the numbers go further down. So, and they also stopped what we were calling step down procedures, which Brandon and I found that they were doing, which they shouldn't have been doing. So that also has reduced some of their numbers as well. And we found that out. I think it was June or July that we may have noticed that. So that's one thing that started to help as well. But with the reduction in census, their staffing levels were much better. And as you can tell, with some of those that closed to admissions and could get their staffing the way it needed to be, then their numbers started to go down as well. So I'm not sure if Western's going to stay this way or not. Once they go back to a full census, time will tell.
Thank you. Any other questions from the committee?
Just an observation. With the impact of COVID and then so-called staffing shortage, and there really should be a threshold established what staffing shortage means, because it's an easy word just to throw out there, but it really should be established what we're talking about. I just wondered if you went back a year before COVID and looked at all these statistics and then compare it to when COVID started, it would probably give you a little bit better baseline of the impact of COVID. And then if you take the variation with staffing, you would actually start seeing whether there was an impact at all, or if we're seeing some anomalies that are new because of COVID. You got to remember COVID impacted staffing and it impacted the clients, the patients, not being able to see visitors, more isolation than ever before, not just being in a facility away from the community, but not being able to see their people. Some of those psychosocial impacts, it would be interesting to see how that compares to pre-COVID years. I think it's a great data to have because it can also help you with looking at staffing and also looking at some interventions that maybe not have thought of because of the impact. Just my thought and observations.
Right, and that's a very good point. And I do have data that goes back that far. This report I've been doing, gosh, for a while, so I could even look at that to do some comparison data, and maybe can have that since the next meeting until November. Could share some of that in November.
I'll also say that the office has been, particularly Brandon Rotenberry and Cassie Pertleball, have been helping us to compare abuse, neglect, and human rights complaint data prior to COVID and during COVID to see kind of the increase or decrease in what population. So I can try to pull together some overview slides as well to kind of buttress what Mary Claire presents next month.
Thank you so much. Thanks, Mary Claire.
You're welcome. I'm going to stay on for my folks, and then I'm going to be going to the beach.
We are all jealous. Okay. So Brandon, are you ready?
Yes, I am ready. I'm just going to pull up my screen. Let's see. All right, so our violation letters in state facilities, this report is actually for July and August, just because of how some of the agenda deadlines fall. In July, there was one violation letter that was issued at Southeastern Virginia Training Center, and that was discovered, identified through the abuse and neglect investigation process. So those investigations. And then looking at August, there were 3 letters. These were also identified through the abuse and neglect investigation process. 2 of those were at Western State Hospital, and 1 was at VCBR, or Virginia Center for Behavioral Rehabilitation. So it's actually a pretty short report for you all today. There's very few letters that went out in those months, but if you have any questions, I can answer those for you.
I have one question. How's the facilities taking and dealing with the violation letters, which I think we just recently started? Has that been a good tool?
It has been a good tool. I think we've been able to use it to show some good corrective actions and track those better. The facility directors actually provided some feedback when we got started, specific to the abuse and neglect investigation process. Typically, in those cases, the facility director is already identifying the violation based on that investigation. So we were able to shorten that process to prevent us sending an extra letter and them sending an extra response. So instead, when they send us a memo letting us know about their findings and that they found a violation, they go ahead and put that directly on that memo saying, we've identified a violation and here's our corrective action plan. So we've been able to shorten that process to make it easier on them. And I think they appreciated that. They were already taking corrective actions. This is just more of a formal way to address it and track it.
Thank you.
Thank you, Brandon.
Thank you.
Tony.
All right. Hi. I will be reading the reports for July and August as well. For VCBR, there was one emergency physical restraint for aggression because of spitting on staff, and there were 3 mechanical restraints. The total duration of the restraints was 8 hours and 21 minutes. There were 2 reported injuries from those restraints, was 1 abrasion to the abdomen and 1 abrasion and swelling and redness to the ankle and wrist. During the July, there were 81 transport restraints. The shortest duration of those restraints were 1 hour and 4 minutes, and the longest was 7 hours. And that was due to a colonoscopy and the travel time for it. Overall time for the transport restraints was 320 hours and 24 minutes. There were no reports of seclusion. Allegations of abuse and neglect, there were 3 allegations reported. There were 2 verbal allegations and 1 neglect peer-to-peer allegation. All of the allegations were unsubstantiated, and they were all investigated within 24 hours. The human rights complaints, there were a total of 8 complaints received, 1 substantiated violation of dignity. All complaints were handled below the director's level. There were no policy updates for the month of July. The construction update, as you can see in those pictures in your pack, pretty much they've improved since then, but I wasn't allowed to go in August to see the improvements, but this is where they were in July. Basically, the construction is still slated to be ended in January. So, all right. Any questions for July?
Sorry, I do think it's really exciting that they've got the women's unit there, right? Because they've always had women receiving services, but they've been at Central State. So it'll be interesting to see the dynamic. And when we say completed in January, we mean 2022?
22.
Wow, it's like tomorrow.
I know this year went by fast. It just flew by. All right. August report for VCBR. There were 4 emergency physical restraints for aggression and 2 mechanical restraints. The total for the restraints was 2 hours and 50 minutes. During the period, there were 98 transport restraints. The shortest was 1 hour and 23 minutes, and the longest was 7 hours and 42 minutes due to a stress test and the travel time for it. The overall time for the transport restraints was 418 hours and 32 minutes. There were no reports of seclusion. Allegations of abuse and neglect, there were a total of 4 abuse neglect allegations reported. There was 1 restraint allegation and 3 neglect non-peer-to-peer allegations. There were 2 neglect non-peer-to-peer allegations that were substantiated. All the allegations were assigned to the investigator within the appropriate time. In human rights complaints during the period, there were 16, and 2 were substantiated violations of dignity. 1 was a substantiated violation of complaint review process. All were handled below the director's level. There were no policy updates, and the construction update, I've added other pictures. These are for basically the outside. I was going to do some before and after, but I was like, there's not enough room for all that. I don't want to inundate them with pictures. So, but the outside, compared to July, this was totally clear because they had just concrete and everything else all over the place, but now it looks a little cleaner. The picture in the top left there, that's basically the meeting room for visitors, and the outside area there is where I guess they're going to have meetings with the residents. I think this is in the transition unit. So when they're transitioning out, they'll be in this area. And that was it for August. Any questions? Thank you.
Thank you, Tony.
Thank you very much. Jennifer, are you ready for the community report? Great, thank you.
I am ready. Yep. I don't have anything to share as far as on my screen, but I've got some updates on some projects and some going on things that we have going on in the community. So the first one that I want to highlight is the classifying neglect allegations project. This is regarding neglect allegations that providers report in CHRS. We had the observation based on data that the majority of the allegations that are reported to OHR allege neglect. The realization that we came to is that we needed to improve our data collection process at that point of entry. And we started thinking about the fact that we have subcategories for abuse and why don't we have them for neglect. So this led us to the first step of retrieving neglect allegations from the data warehouse within a certain period of time. And the discovery dates that we chose were October 1st, 2020 through March 31st, 2021. We did filter the cases. So we were just looking at DD services and waiver recipients, and the cases would be entered by CSBs or community providers. We did not include the facilities in this project. There were a total of 485 allegations that met this criteria, and these allegations were divided among 9 designated reviewers to manually review the abuse description. 45 of those cases were randomly selected allegations that were reviewed by all reviewers. So they were shared cases, and that was to help determine the inter-rater reliability within our reviews. So the next step, we worked with the Office of Data Quality and Visualization. They developed a really cool Microsoft Power App that gathered data from the warehouse and from CHRS. And we each had our own app that we went through and reviewed the cases. So each CHRS report was reviewed using the app. And what we did is we categorized those cases into different options. So the first 3 options were a select all that apply, and those were med errors, elopements, or AWOL, and then failure to provide nourishment, treatment, care, goods, or services. We also had 2 options that served as exclusive options, and those were if we identified something that did not fall into neglect category, or it was not neglect, or there was insufficient information in the description to allow us to make that determination. The next step, the data was analyzed by the Office of Data Quality and Visualization, and they found substantial agreement among the 9 reviewers. And so from that, we came up with some conclusions and next steps. Some of our conclusions were that we identified appropriate subcategories of neglect. The next step that we're going to work on is to work with IT to integrate new neglect checkboxes in CHRS to help providers and help our office identify those subcategories of neglect. With that, we exposed the blessing and burden of the 2 categories that were exclusive, the indeterminate and the non-neglect category, which we think we can use that to increase training and resource development that we provide to the community providers. Next, the existing data sample looks like it can continue to trigger progress. And so we'll analyze trends in order to mitigate and reduce provider neglect. Any questions on that? We do have a really in-depth PowerPoint that I could share, Tanika, if you think it would be helpful with the committee, if you want more information. I just wanted to give kind of a snapshot of that project. Okay.
I see heads nodding. I think that was good. Thank you. Thank you.
Yeah, sorry. I just wanted to give an opportunity for questions before I moved on to the next one. We have a lot going on right now. So another project that OHR has been involved in that's community specific, and some of you may have heard about it. It's the Connect system, which is the new DBHDS licensing system. While that system is specifically designed and will be utilized by the Office of Licensing, OHR has been involved in some development and testing with that. Several of our staff have helped with that. Cassie Pertiball has been really instrumental in the testing process and providing feedback. And the reason we're involved with this, as you all know, when we issue human rights citations, we refer those to the Office of Licensing, who actually issue on our behalf. So this new system, it will be, handling other Office of Licensing procedures, but it'll also be processing the caps through the new system. So we're going to be involved in that piece. Right now, they're in the final stages of the development and the launch, and they're preparing for staff training and other readiness tasks. Actually, on Monday, October 4th, is the first Connect virtual training course. All of our staff in community operations side will be attending that training, and then we have other specific trainings that are kind of split up by region, and we'll be participating with the Office of Licensing counterparts. And the system is expected to go live in November. So maybe at the next meeting, I'll have another update on how that's going. Another program or a project that we've been working on, I don't know if you all are familiar with the HCBS settings rule that community DD providers are having to come in compliance with. So as part of Virginia's statewide transition plan to ensure compliance with the HCBS, which is Home and Community-Based Services, CMS has involved DMAS and DBHDS to conduct 400 on-site reviews. The vast majority of these reviews, around 332, are being completed with the CRCs and DMAS reviewers, and they're just considered regular reviews. There were 68 locations that were identified as heightened scrutiny reviews due to really their institutional nature. And OHR was brought into that process, and we've been assisting in these reviews. So we've had 4 advocates, and Tanika and I helped out and did a couple too, because we had kind of a short time frame. I think it was from July until September that we needed to complete these. But we had 4 advocates across the state help participate in these extensive reviews. These are really our advocates with a lot of DD background and experience, which was really helpful in the process. And I want to commend them for doing that, because this was totally in addition to our regularly assigned daily duties. So this was an extra project for them, and they've done really well with that. So let's see, another update, and I'm doing okay with time. The human rights regulations are currently in the periodic review process. And in preparation for that, gosh, I guess it was earlier this year, maybe even last year, our office had the ability to provide feedback on suggestions to changes that we would like to see within the human rights regulations. We tracked all of this information and then formed a smaller work group within OHR, and it's kind of led by Ruth Ann Walker, who's the Director of Regulatory Affairs. We started meeting weekly to review the comments from our office, and then we received other comments from the CSBs, and we've been taking that information and working through it together in our regular work group. And Ruth Ann was working on drafting or making a draft of the regulations, including those items from our discussions. So right now we're still in that process, and we're meeting bi-weekly to go through the draft and work on finalizing the language and clarifying any revisions. And then Tanika, I'm sorry, but I am having a hard time remembering like where we go after that. Then they go up for public comment.
Exactly. Yeah.
Okay.
Yeah. So once we have a final draft revision, it will go back out for public comment. It will at some point in between there get reviewed by the Office of the Attorney General to make sure we're not, breaking laws with our suggestions. And then after there's that public comment period, it comes back and gets blessed by the governor and it continues. So we're still probably at least another 18 months out. But important work is happening nonetheless. And it's kind of fun. It's a bunch of nerds, and I'm one of them on this work group. It's super fun.
Are there any changes or recommendations that involve COVID or as a response to what we've been through with the pandemic?
Yeah, I can speak to that. So I think a lot of the revisions, and one of the steps I failed to acknowledge is there's going to be it's called a RAP, like a regulatory action group. I don't remember what it stands for, but essentially we get stakeholders. So I would imagine there'd be a rep from the State Human Rights Committee, some individuals receiving services, providers, different types of providers, CSBs, so that they can review the revised draft as well and give some feedback. So that's an important step, and you triggered that for me. Thank you, Monica. But some of the changes really have to do with processes and making things a little bit more transparent and more simple. I don't want to say it's directly tied to COVID, but COVID taught us a lot. COVID kind of beat us up with, particularly, and we'll talk about this on our agenda, the way that our local human rights committees have operationalized their reviews. And there's some, for lack of a better word, there's some impotency there, right? Like we've got a lot of decision making happening, but then, there's some barriers to that. And so we want to make sure that due process ultimately is not impacted by the individual. And so a lot of the revisions have to do with kind of cleaning up the language, making it more clear where things go, when they go there, who does it. So I know that's super vague, but I hope that answered your question.
I would imagine so, because I know we've, had to go to remote style working, and, it altered the LHRCs and even how we do what we do. So I figured that some of that might be written into any revisions to the regulations. So, okay.
Okay, and I'm almost finished. Just want to give a new update on our new staff in the community. Back in June, Region 3 hired Chelsea Robinette as a new advocate. In Region 5, Corey Reed was hired in August as a new advocate. Right now in Region 4, we have recruited and interviewed for a new advocate. And we actually have made a recommendation to Human Resources. So we're waiting to hear something soon, hopefully, about if that person accepted the position. Also, we are now going to have a statewide admin position. And this position will provide administrative support to the OHR management team for facility and community operations. And we also recruited and interviewed, and a recommendation has been made for that position with Human Resources as well. So we're hoping to hear back soon. And a lot of these positions were kind of open when we made the transition from, having a community and facility operations together to splitting them up. And then COVID kind of delayed the hiring of some positions. So we're just kind of getting back to where we're going to be fully staffed. So that's exciting. Do you all have any questions for me or any comments?
Hi, it's Tim. And when I heard you were doing subclassifications, the database geek in me went awesome. So I just wanted to say that.
Okay.
Thank you so much, Jennifer. I appreciate it. I have one quick question, just because when you were talking about inter-rater, reliability, that connected to me. So what was the percentage of reliability that you found? Do you remember?
I can pull it up.
If you don't know off the top of your head, that's okay.
I think it was, we used, and I'm probably gonna not pronounce it correctly.
I think it's like FICE.
Slice
or Clice or something. I can't.
Slice,
one of those. Yeah, there's like different measures.
Yeah, and 0.67 was substantial agreement. And so it fell into that 0.61 to 0.80 with Fleiss Kappa. But then we also had like 24%, I believe, that we were in complete perfect agreement. So it's pretty good, considering we had 9 different reviewers. But definitely, I think we can use the data to inform our processes and improve our training with providers.
Great. Thank you so much. I appreciate it.
Sure.
And if you could talk to the IT people about making sure Chris doesn't freeze while you're using it, that would be great too.
Oh, trust me, it happens to us too. So we know. I'll do that.
Thank you so much for your time. We appreciate it.
Okay, thanks.
So to the committee, we have a little bit of time before our next section. So why don't we take a 10-minute break, reconvene at 11? Does that work? Okay, thank you.